okay? In my honest opinion lah. It's difficult to diagnose, okay? Siti will tell you about that. Most of the time, rickettsial is mild, okay? But you would see people who die. You would see people who come with severe sepsis from rickettsial, okay? And that's the problem, okay? We cannot just simply throw in the good old cheap doxycycline to everybody, okay? Because resistant issues have been raised in northern part of Thailand, in Chiang Mai and Chiang Rai. They do see rickettsial that are a bit refractory to doxycycline treatment, okay? Hence, we don't want to create unnecessary exposure, although we can agak-agak rickettsial by probably the epidemiological link, or if you're lucky enough, you found an HCA. But most of the time, we really need a good lab diagnosis of rickettsial infections in the end of the day for many reasons, okay? Next slide. All right. Okay, this slide pretty much highlight rickettsial. Okay, in the end of the day, we used to understand rickettsial. We used to dichotomize gram-negative into extracellular and intracellular. Those who can be cultured extracellularly, i.e. on your blood agar, your chocolate agar, your McConkey agar, are the non-rickettsial, your E. coli, your Klebsiella, your Burkholderia, blah, blah, blah. Those who cannot be cultured extracellularly, those who needs a cellular culture, they just lump it into rickettsial. So that's happened many years back. So with the advance of PCR, okay, nucleic acid technology, the 16S ribosomes, the scientists realized that they are more than a simple rickettsial. Okay, now we know there's anasplasmosis, we know there's ehrlichiosis, neorickettsial, and we know that Orencia susugamushi is not at all similar with your other rickettsial species. Hence, scrub typhus is already out from the same species from your rickettsial species, but from the similar nature of intracellular culture needed, so scrub typhus is still lumped under rickettsial infection. So at this moment, when we talk about rickettsial infections, okay, our idea which should go into scrub typhus, murine typhus, and spotted fever group typhus. Okay, but bear in mind there are other so-called rickettsial infections from other vector-borne infection, which are predominantly specialized on different locations in the world. Okay, so in our context in Malaysia, okay, we are dealing with scrub, murine, and spotted fever. If the war in Ukraine and Russia get bad, okay, epidemic typhus may happen again. Okay, the fleas from human to human will transfer the Rickettsial Prowazekii and cause death. Okay, but that's a different story. Today, we just concentrate on the three most important zoonotic-borne infection that cause rickettsial, in which scrub typhus by Orencia susugamushi, murine typhus by Rickettsial typhi, and spotted fever group rickettsial by multiple rickettsial strains. Right? I will start. Okay, why this is important? My head is hiding the important, important things lah. Sorry. Okay, you can see the p-value there, right? Whose idea is to put image on the slides? Why I'm saying that? What I'm saying is, rickettsial patient do die. Okay, you can see that rickettsial, 4 of them die in our study. Okay, leptospirosis also die. Rickettsial infections do have a severe sepsis by Q so far. Okay, in the end of the day, not all rickettsial are mild. Not all rickettsial are can be saved by your doxycycline. They still die and they still present with septic shock, for example. Just a simple slide to show that this is what happened in Teluk Intan. Okay, you are 20 times risk to die from dengue, from leptospirosis, 10 times to die from all rickettsial infections from dengue. Okay, again, in the end of the day, mortality happens. Okay, morbidity happens in those patients infected by rickettsial infections. So I'd like to show you our first case. Okay, this is a young guy. Okay, young guy, 23-year-old. He is an orang asli from Bukit Payau. Anybody in the audience from Bukit Payau? Tak ada angkat tangan So nobody from Bukit Payau. He came to us with fever for 5 days. Okay, very unspecific symptoms: chills, headache, arthralgia, myalgia. She vomited. He had a cough as well. Just acute history. Okay, on examination, he's febrile, hemodynamically stable. This is pre-COVID era, so we were not worried about COVID infection at this point. On examination, we could feel there's right cervical, palpable lymph adenopathy, and right pleural effusion. Okay, of course, the doctors will treat as community acquired pneumonia. Okay, they started him on typical treatment regime using azithromycin. So that's the finding. And so this is the blood results when he came in. He came in with platelet of 123, creatinine of 122, very much raised liver enzymes. Okay, now screening by lepto IgM negative, dengue NS1, IgG IgM negative. We took blood culture, did not grow anything. We did malaria blood strain, did not see any parasites inside the erythrocytes. Okay, ultrasound liver, no abscess. At this point, patient is treated for community acquired pneumonia by evidence of the right pleural effusions. Okay, although it's a bit rare to have localized lymph nodes in your typical community acquired pneumonia. He got azithromycin, he got ceftriaxone 2 grams a day. The fever settled. Okay, the fever settled. But are we happy with the diagnosis? Can I ask people or cannot?
You mean personally? I mean, you want them to respond to your question, Dr. Yazli?
Yeah, can I do that or cannot?
I think boleh. Kalau ada yang boleh nak jawab, maybe you can raise your hand and our secretary can help lah to unmute their microphone. Yeah.
So anybody out there
can answer dekat chat juga atau Q&A. Yeah.
So my question here, if you do rounds, okay, and you see, okay, this guy, right pleural effusion, responding very well to azithro and rosafin, no more fever, he feels better. But you still don't have the microbiological diagnosis, okay? Are you happy to stop here or you want to venture more? Or you don't agree with the diagnosis? That's my question. Anybody?
You may also type your response dekat chat or Q&A session, participants.
Oh, Prof Syafinaz may want to just give her thoughts.
Open to our participant lah, Dr. Yazli.
Yes.
Has raised her hand.
Hello.
Yeah.
Dr. Yazli, very interesting. So I wouldn't be happy because in Malaysia, I think TB is still one of my differential.
Okay.
So I will go ahead to continue investigate for TB.
Okay. So yes, pleural TB can present very acutely. I agree with Peng, but you would expect the fever to be still there, right, Peng? If this is TB pleural, agree?
Yeah, sometimes yeah.
Yeah, you can argue sometimes there might be element of the antibiotic killing the mycobacterium. But if I say he completely well, fever completely settled with this combination of antibiotic, okay, you would think of TB. I said probably not TB because he responding. We did not tap him. Any other apart from, okay, so you are focusing your diagnosis on the lung infection lah kan?
Lymphoma is another possibility.
We are doing infectious disease, not hematology, so forget the non-infectious disease diagnosis. All right, but that as a physician should think of that. But this all of these cases are non-hematological, non-connective tissue disease, non-bomoh-bomoh pawang-pawang punya kuman. Okay, so what Dr. Peng said was correct. Okay, she wanted to expand the differential diagnosis, which is good, because most of the time we just most of the time, okay, maybe when Pang did her round, she will ask different things, but most of the time when patient responded to the treatment, we just tutup buku and forget about it without knowing what is the microbiological cause. Okay, I wouldn't venture much to TB due to the clinical response that the patient showed. Okay, but yes, being in Malaysia, pleural TB, extrapulmonary TB is important. Okay, you might want to know his HIV status and whatnot. But in this study, what we did after this is Siti don't want me to show this for multiple reasons, but I'll just show you this. But this test is good in a certain ways, but it can be so crap as well. Okay, so this is the rapid test for scrub typhus. So we did a rapid test for scrub typhus in all of our patients in this study. Okay, so this guy, his rapid test for scrub typhus was positive. You can see the second line there. Okay, so that is the diagnosis by the rapid test. When we proceed with the IIP, so indirect immunoperoxidase serology, okay, IIP is almost equivalent to the IFA, immunofluorescence antibody. So the difference is just in NIH, we use light microscope to see the antigen reactions, okay, but in some centers in Mahidol, Thailand, for example, we use the fluorescent just to make it easier to be seen lah. So we proceed with the serological diagnosis for scrub typhus for this guy, and who and below, okay, the titer was so high, 1 in 1600. Okay, this is on day 7 of illness. Okay, what else did we do? We proceeded with PCR. Okay, so you can argue, I think 3 years of COVID, anybody knows CT values. CT value too high, maybe not positive lah. So his CT value was what we ran 3 cycles of the PCR, okay, the real-time PCR, which the first CT value was 41, 43, 39. Okay, bear in mind that this PCR was done on day 7 of illness, 3 days after this guy received azithromycin. Okay, so the serology is positive, the PCR, although the CT value is not that low to our liking, okay, but we still consider as positive because of the nature of the illness. Okay, so in the end of the day, this is the diagnosis of this guy. Okay, 28-year-old man, okay, unspecific symptom, right pleural effusion. Everybody will think of community acquired pneumonia, but okay, if we look at literature, scrub typhus, Orensha susugamushi does cause pleural effusion. Okay, so in other words, it is part of should be part of our atypical pneumonia regime, in which it is quite interesting, because most of our cocktail of antibiotic in those with pneumonia would be one beta-lactam and one non-beta-lactam, either azithromycin or doxycycline. Okay, agree? So that's why those patients in Teluk Intan who presented with lung findings, they're all alive from rickettsial infection, because even the doctors didn't know that they have rickettsial infection. The doxy or azithro is there. Okay, those who died, you will see who died. Those who died, actually those who come with atypical presentation. Okay, no lung finding, so they did not get the element of doxycycline or azithromycin. This patient died. Okay, so I'll show you the case. But this is the diagnosis of scrub typhus in a young orang asli man with right pleural effusion by serology and also by PCR. Dr. Siti will talk to you about this. We managed to get a band protein from this guy and to make a strain. Okay, so the strain comes later. Okay, so that was the first case. All right. Ridwan said ada 2 orang angkat tangan. Angkat tangan as in soalan ke dia nak angkat tangan?
I've allowed Dr. Prof Asrul and Dr. Nurhanis to speak if they have any questions.
Okay, silakan.
I think you can continue, Dr. Yazli.
Any question?
It's either maybe they tried to respond to your question earlier. If not, our Q&A will be after the second presentation. So Dr. Yazli, boleh continue dulu? Yeah.
All right, so the second case is very interesting. I did not believe that I'm seeing the case because I thought I wouldn't see this case, okay? 40 years old, Indian man, 10 days of fever, headache, myalgia, rash. Again, apart from the first guy, this guy had rash, okay? The first orang asli did not have any rash. He drives the lorry that carry the minyak sawit, the buah sawit from ladang-ladang Intul Intan, the many ladang sawit. Okay, so the first thing he told the doctors, I saw many tikus running along the on my boot and whatnot. And of course, the diagnosis is leptospirosis again. Everybody will say this is lepto lah, tikus. Temperature 39, hemodynamically okay. There's no conjunctival suffusion. There's no palpable nodes. There's no eschar. We noted there's macular papular rash over the lower limbs. Okay, and there's no myositis. All right. So very mild presentation of infection. Q so far 0. Blood. Unlike the first guy, his creatinine is fine. The liver function is not as bad as the first guy. CRP-CAT that's raised. We did procalcitonin 0.9, slightly raised. Okay, not that much, not that high to my liking to say, "Whoa, this is very bad infection." But true enough, from the bloods we can say this is bacterial infection rather than viral. Okay. So because of the impression that patient gave to the doctors, I saw a lot of rats, okay, and no other finding to suggest of anything else. He got Roszilawati lah kan. This is, I think, most part of practice in Malaysia will do. He got Roszilawati 2 gram OD. The dengue NS1 negative, the blood film malaria was negative, the blood culture taken were no growth, the leptospira IgM was positive, the first MAT, okay, was 1 in 200. In the LEP 175 serovac. The rapid diagnostic test for strep typhus that we did, like for the earlier guy, was negative. So this guy, 10 days of illness, he stayed 3 days in the hospital with Roszilawati 2 gram OD, still fever tak turun-turun. Question, what else would you do? Apart from Pang lah, somebody else?
The participants may raise your hand to talk to the microphone, or you can also type in the Q&A or chat box.
Talk to the microphone lah, senang. What would you do now? Examination, no organ finding. Okay, liver is okay. You don't think it's abscess there. But this guy just did not respond to the Roszilawati. Anybody? Shall I proceed? Yeah. Nobody want to try?
There's a message dekat Q&A. Take a second blood culture.
Okay, second blood. Why would you take the second blood culture? Okay lah, no lah. Okay, so no. Okay, you take blood culture and you change antibiotic to melioidosis, for example. If I were if that is Siti Kairani's idea, so we want to say that this might be melioidosis, okay? Because although he's not unwell, he doesn't respond to your typical non-beta lactam for melioid. Repeat blood culture in case you want to see the Burkholderia pseudomale and change to ceftazidime. That should be your approach kalau you nak buat repeat blood culture lah. I couldn't think of any other culturable bacteremia out there that should not respond to Roszilawati apart from melioidosis. Venture into atypical pneumonia investigation and treatment. So the lungs were clear, the X-ray were clear. I wouldn't want to think of pneumonia at this point. Okay, UPM. I think that's my response. Pang, can allow chat function, please? I don't know.
Dr. Pang, you can also type there your question or your response.
The chat is disabled. Oh, okay.
Dr. Yazli, this is Murni from MR.
Hi, Murni.
Hi. Actually, I was thinking the same about melioidosis or any deep-seated abscess. So probably ada radiological investigation to approach for any deep-seated abscess.
So usually in melioidosis or disseminated abscess, okay, clinically they would be more unwell than this guy. His so far was 0. I would expect the PCT to be high lah. Cikai-cikai pun 5, 10, 20. Okay, so biochemically that's how my approach to anybody with severe gram-negative infection. Okay, clinically there's nothing to suggest of abscess in the abdomen, in the liver or spleen. Lungs are clear. Yes, I agree with you. I did not have his X-ray, but his X-ray are normal. We did not proceed with any ultrasound yet because what I did was something else. All right, but yes, I would think of melioidosis if he is more septic, biomarkers is higher, regardless of no findings clinically, I would proceed with imaging, ultrasound or CT scan to look for abscess. I would repeat the blood culture and stop the Roszilawati and change to Fortum. Okay, but in the end of the slide, you will see that the rate of melioidosis in Teluk Intan is low. Okay, I don't think we have a lot of melioidosis in Teluk Intan as much as in Upper North Part or in Pahang. All right? But you are right. Any other thought? So what we did after this was this. So again, I said the rapid diagnostic test for scrub was negative. The IFA and IIP for scrub was also negative. We proceed with rapid test for murine typhus. Okay, so these are the test well. Okay, these 2 holes are the test well. It should be positive there, but these are your reactive well. So to say that somebody has acute murine typhus infection, there will be 1, 2, 3 round shape in the reactive well. So this guy had 3 round shape. Okay, so taken on the 11th of illness. Just because of the rapid test too, we of course started him on doxy, but this was his IIP for the murine typhus. It is 1 in 3,000 on the day on the 11th of illness, and 1 in 13,000 in the convalescent sample. Okay, by equivalent to IIP, right? So you can see the staggering rates of serology. Okay, from this guy on Rickettsial typhi infection, murine typhus. We also did ELISA, the optic disc, but this is still very much under study. Okay, but any measurement of more than 1 is considered positive. Okay, so we just compare the IFA with the ELISA. But this guy serologically is murine typhus through and through lah. You can appreciate the more than 4-fold rise of the serology in this guy, the IgM. So we started him on doxycycline. Okay, he got Roszilawati here, and then we started doxycycline here. Bang, you can see the fever settles. Typical of Rickettsial infection. Rapid response to doxy. The problem in this guy is he says he saw rat. So people think rat equal to lepto. Cannot lah, because in the ears rat you can see the mites. It triggers that. In case of murine typhus, the fleas from the rat is the one that is the vector that will jump to you and bite you and pass you the Rickettsial typhi and get the disease. All right. So this is a guy, he consented for his picture to be taken. Okay, they are happy once the fever settle. All right. So this is a very interesting murine typhus case that I first saw and first diagnosed in this study lah. All right. Okay. So first, not bad. Scrub typhus. Second, not bad murine typhus. Okay, this is the third case. Again, young orang asli, 28, 7 days history of very unspecific symptom, tapi ada diarrhea. Okay, lethargic, myalgia, arthralgia. He mandi sungai almost every week, but interestingly, he said on the last time he mandi sungai, he said he nampak lembaga hitam. Okay. So lembaga hitam, saya besar ke kecil tak tahu, tapi nampak lembaga hitam, whatever lah. So on examination, he was really unwell. Okay, you can see that the blood pressure was low. He's very much tachycardic. Okay, he's not confused. Lungs were okay. He came with septic shock. Okay, unlike the first two cases, this guy came with severe sepsis, septic shock. No rash, no eschar, no nodes, no hepatospleno. Eyes were fine, lungs were clear. Okay, so Peng, you agree we enter him to ICU or HDU? Mana-mana lah but this is not a good infection, correct? Correct lah White cell, predominantly neutrophils, 20. Platelet, low, 90. Creatinine, raised, 300. We never had his baseline, but assume this is acute kidney injury. Low potassium, low sodium, raised liver enzyme, just like the first orang asli guy. CRP6, again, PCT not that high. I would really expect somebody with septic shock, if this is really a bacterial infection, the PCT will be higher than 0.4 lah. So again, this is something a bit off in terms of procalcitonin presentation in somebody with bacterial septic shock. All right. Ultrasound of the liver, just hepatosplenomegaly, no abscess. He was very sick. Of course, orang asli, they empirically started him on Roszilawati and doxy on the same day. Okay, Roszilawati and doxy on the same day. Lepto IgM positive, lepto MAT negative, dengue negative, malaria negative, blood culture no growth. Diagnosed was septic shock with hepatitis and AKI. 1, 2, 3, 4. On day 3, we managed to take off the inotrope, but fever never settled. Any takers? Any response? Anybody wants to argue what's happening now? Anybody? No, yes, okay. So what we did was, of course, the usual thing. Okay, this is his rapid test for scrub typhus. It was positive. Okay, the IFA was positive again, 1 in 12,800. Okay, that's super high. But in the end of the day, he responded. Okay, so I just show up this case to show that I'm not saying this is a resistant doxycycline treatment, okay, but we do see in case report those who responded quite late to your doxy, your typical doxy. The classical teaching of Rickettsial or scrub typhus is doxy, fever settle, then confirm doxy. Don't need to think right? So that might not be true, okay. If we don't have an access to a diagnosis, I'm sure you would throw in meropenem already at this point. I'm sure you would throw in vancomycin at this point. Okay, unnecessary antibiotic, expensive antibiotic, stewardship habis ke laut. Okay, so with a good test, you can just simply make a good diagnosis and you know the treatment should work. Okay, we never heard of doxy-resistant Orangea susugamushi in our country just yet. Maybe because we did not look hard, but it's quite rare to find one. But in the end of the day, patient do respond. Fever do settle, okay, with a good diagnosis of scrub typhus. Fourth case is something else that quite different from the first 3 cases. 33-year-old, fever for 4 days, lung symptoms, living telur intan, shock, sofa 2 because of the tachypnea. Bilateral crackles on the lungs, no rash, no eschar, no eye sufficient, no hepatosplenomegaly, they think of pneumonia, fair enough. Platelet 150, lactate was 3, PCT was 4. Okay, this is the highest procalcitonin as compared to the first 3. All right, remember that. And then this is her X-ray. Okay, for some reason I have her X-ray, I don't have the previous X-ray. I can't remember exactly why. Okay, but this is pre-COVID era. Dengue negative, HIV negative, blood culture negative, Rickettsial investigations were all negative. We ventured with UPM, okay, Syafinaz, no people there. So this lady was diagnosed as Leptospira interrogans infection, okay, leptospirosis. This is a typical leptospirosis, what I'm saying. Leptospirosis, they came with bad, but can be bad as our third Orange Susugamushi, but clinically, I mean, biochemically, it would be a bit of different. PCT is much higher in your extracellular gram-negative. Okay, being an intracellular gram-negative Rickettsial infection, they behave like virus. Okay, so we use procalcitonin to differentiate between viral and bacteria. That's the line. So being an intracellular gram-negative, they almost behave like virus. Okay, so your PCT would not be as high, walaupun you datang with septic shock like our third orang asli guy. Okay, but this leptospirosis is classic, typical shock. You would expect the biomarker to be a bit more excitingly high compared to your other viral or intracellular. Okay, so she survived, fine. So those 4 cases are cases that we saw pre-COVID era. Okay, then after then COVID havoc, we stopped studying, we just concentrate on COVID. And this is the recent cases that Dr. Siti is aware as well. Okay, in private practice. Okay, post-COVID. So 33-year-old, boosted. He's a contractor worker from Klang, referred to me for fever unresolving on ceftriaxone, fever, headache, and cough. His lungs also got pleural effusion over the right, but for some reason this guy was only treated with roxifene alone, ceftriaxone alone. So dengue negative, COVID negative, influenza negative, roxifene negative, 1, 2, 3, 4, 5 days on the ward, fever never settled. Okay. So when I saw him, of course, I got an extra history. He works in multiple factory in Meru, dekat ladang sawit tu. Okay, so when he stopped by, he will sit on the ground, bawa pokok sawit, tunggu the people to offload the lorries and stuff. Okay, that's what he do. That's what he does. So on examination, nothing much of vital signs were quite fine, except there's a reduced air entry in the right lower zone. Okay, urban patient with fever who always recalcitrant to antibiotic. I always make a habit to do the bedside fundoscope just in case this is HIV. Okay, you might find some clues that trigger opportunistic infection. The bedside fundoscope was normal, but the impression there was reduced right lower zone entry. Okay, there's rash on his chest. Okay, this was his PCT. For some reason, it's 2.3, a bit high. The fever never settled until when we do a thorough examination. Okay, we found a scar. Okay, so that there's an scar on his left thigh. Okay, which prompt to the diagnosis of either scrub typhus or spotted fever typhus. Murine typhus, the fleas do not leave an scar. Only the ticks from the spotted fever and the chigger from the scrub typhus give scar. Okay, scar is when the skin react to the bites to the organism and leave your part of the skin become necrotic. Okay, so this is what we found. This is interesting because most of the organism, remember, they are all intracellular. Most of them reside in the skin, okay, before they go to other part of your cell, your dendritic cell and whatnot. But the highest load will still be there. So what we did, like monkeypox so monkeypox to diagnose, you have to scrape the skin. For this guy, we scrape the top layer of the scar, okay, and just left a little bit of bleeding there. And okay, so remember the four cases that we present, only this guy had an scar, the others tak pernah ada scar. I'm not surprised because if we read up literatures, scar rate is low, okay, as low as 4% in Bangladesh, 5% in our study in Teluk Intan, a bit high in Chiang Rai, 30%. Okay, so but in the end of the day, not everybody will come with scar if this is scrub typhus. It's not a foolproof requirement to make a diagnosis. Okay, so we're not surprised why we haven't seen scar much in Teluk Intan, but this guy had scar, make our life easier. So we send the scar to Dr. Siti in IMR. Okay, if you can screw your eyes enough, you can see that the PCR was detected. Okay, so this is his IIP. the IgG raised by more than 4-fold from the 2 weeks apart. Okay, 2 weeks. One in 1,000 to 1 in 600. Okay, so it's not just the PCR was positive, the 4-fold raise in the antibodies also confirm our diagnosis of Ornithia sussugamushi infection. So we started him on doxycycline, and of course the fever settled. Okay, eventually the fever settled. He responded. He responded promptly. A typical scrub typhus infection. Start the doxy, fever settled. Urban patient. This is my colleagues, Dr. Roszilawati. She also referred a pregnant lady, fever never settled on the ward, on tezocin lah, apalah. I did not get the clinical history much, but when referred to ID, Dr. Anila found an HK there. Okay, so she sent this to Siti in IMR. It was also detected, but because pregnant, Anila started her on azithro, boom, fever settled. Okay, this lady is a housewife. Okay, she doesn't go to pregnant some more. Okay, she doesn't go to ladang sawit or whatnot, just in house. But when we talk with each other, Dr. Adila, Amin, so typical Kota Baru punya kampung lah kan. It's not just panda. So you have scrub areas, you have rats, you have rodents. Again, those are very important clues to making diagnosis of rickettsial infection. So this is scrub typhus diagnosed by PCR. Okay, that was sent from the HK scabs to IMR. Again, typical scrub typhus, they hide under the ground. Okay, the chiggers too. The chiggers are the life stage of the mites. Okay, the trombiculite mites that only come out from the soil and feed on you once in their lifetime. Diorang makan sekali aja seumur hidup. Okay, tapi kalau you unfortunate enough, the chigger comes out and feed on human, we might get Ornithia sussugamushi. Again, the mites also resides in the ear of rodents. Okay, so it just not just you have been to be exposed to scrub area or bush area or forest area to get scrub typhus. Okay, if you live in Kota Baru, for example, with rodents running around, okay, or you may get scrub typhus as well, because the chigger, this all hiding in the mouse ears. They're very small, it cannot be seen by your naked eyes lah, not like your kutu, typical kutu. That's for scrub typhus. For murine typhus, the fleas they don't bertelur in the ears, they just feed on the mouse or rodents or cat, and then they go away to other mouse, rodent and cat. But if the fleas jump, okay, the fleas jump to human, they can give you murine typhus. Okay. Spotted fever typhus different. The ticks, okay, the ticks ni can have many perangai. Okay, some ticks melompat, some ticks menyerang. So far, Ornithia chiggers and fleas ni they opportunistic. They're not targeting human to feed. Unlike ticks, okay, that's why some HK is found in the head from ticks, because the tick jump from higher pokok to the human heads. Okay, you get HK in the head. That's usually spotted fever. But for Ornithia sussugamushi, your HK distribution is actually at the discrete part of the body, tight and damp. Okay, so usually around the underwear area and breast area. So on our routine physical examination, we rarely look into this part of areas. Okay, so if you think of HK for whatever reason, look at the groin area, look at under the breast area. That's where the mites bite you for Ornithia sussugamushi. This is a quick case, a patient who died, 53-year-old, 2 days aja demam, headache, seizure, generalized body rash. She's a vegetable farmer in Teluk Intan. QSOFA 3, confused, shock, banyak rash. PCT again tak tinggi. Okay, no LP was done because of takut ni. She got Rocephin, high dose, and acyclovir. The diagnosis was meningoencephalitis. Because I changed the slide, I cannot show you. So scrub typhus negative, murine typhus negative, but spotted fever was positive. Okay, she died. She died because of I mean, any CNS infection mortality is high, but she died because she did not get any azithro or doxycycline coverage. Okay, so this is what happened in most practice. Those without lung complaint, you don't give the atypical cover for pneumonia. Okay, this lady came with CNS infection. You read up literature, Leptospira CNS high, Rickettsial CNS infection high, it presents. Okay, so although the symptoms most are very unspecific, some patient would present with severe infection, then that will lead to death if we don't treat. Unfortunately, we did not start her on any anti-rickettsial antibiotic. Okay, so she died from spotted fever typhus. All right, skip this one. One of the first study in Temerloh, 1980s. Okay, they do found scrap typhus and urine typhus and spotted fever as part of the predominant infection in Temerloh. Okay, this is good 30-40 years back. Okay, so I believe until Merdeka, until today, Temerloh is just like Temerloh lah. You don't have KL Tower there, you don't have LRT there, sama lah. So epidemiologically only KL aja berbeza. Temerloh ke Teluk Intan ke Kota Baru ke Gua Musang ke still penuh dengan musang. Tak ada benda lain di Gua Musang. So what I'm saying is epidemiologically we should not expect anything to be different outside KL. Okay, if there is scrub 30, 40, 50 years back, there will still be scrub there in Temerloh. This is Prof T, serological background diagnosis in all major hospital patients. Okay, the green are scrub, the red are murine, the blue are spotted fever. Quite prevalent percentage of serological presence among patients admitted to major hospital in the peninsula. Okay, so we know the disease there. So,
Yazli, sorry, possible to conclude dalam masa 2-3 minit?
Boleh.
Okay,
so we ignore this, but the disease are there in Sabah. So we did our study in Teluk Intan. So this is what we found. Okay, zoonotic infection, arthropod-borne disease are there. Okay, forget about your blood culture. Okay, in some part there's not much of culturable bacteremia. You should concentrate, put your money on PCR. Okay, diagnostic test to catch your leptospirosis, to catch your scrub typhus, to catch your murine typhus. Okay, dengue is easy to diagnose, NS1 is easily available. What I'm saying is, yes, blood culture is important, but most of the time you're dealing with zoonotic infection in which traditional culture is not going to play important role. Okay, so in the end, I think what we should think is we don't have to throw doxycycline to everybody. Okay, you should suspect somebody with rickettsial infection if they have symptoms, any symptoms, but typically headache and rash, who had exposure to rodent. Rodent does not mean lepto. If you think carefully, even mild lepto you can still treat with doxycycline. Okay, so if this patient had rash, headache, fever, okay, rural setting, rodent exposure, rainy season, that's when the mites come up to bite on you, NS1 negative, CRP low, you have PCT, use it. Okay, then empirically treat for possible rickettsial infection. Start aja doxycycline alone. Okay, if patient not in shock, okay, doxycycline alone without rosafen pun is okay. Send your whole blood, okay, to and serum to IMR where we can clinch the diagnosis and help you to make a diagnosis. Okay, there's not much vaccine in rickettsial. With that, I say thank you.
Okay, thank you very much, Dr. Yazli. Maybe Dr. Yazli can stop sharing and Dr. Siti Rose can start sharing while I introduce you. In the meantime, I noticed that there are some questions in the chat box. Especially by Dr. Siti Khairani and Dr. Jama'iyah. Can you just retap your question and indicate which patient so that we can address again after the second presentation, yeah? Okay, thanks. And it is my pleasure to introduce to you our next speaker, Dr. Siti Roszilawati, who is a clinical microbiologist and infectious disease researcher at Institute for Medical Research. And in addition to having a Master of Pathology, because she's a pathologist, she also has a PhD in molecular microbiology from Germany. And she also has interest in research, and she has published a number of scientific papers on leptospirosis, drug-resistant bacteria, and tuberculosis. Her focus area is on tuberculosis and zoonotic diseases. And she's going to talk to us on rickettsial disease, eliminating the blind spot in laboratory diagnosis. Let's welcome Dr. Siti Rose.
Thank you, Prof. Syafinaz and the organizing committee for giving me this opportunity to talk today at the first CME for Malaysian Zoonosis Interest Group. I still cannot share my screen.
Yeah, Dr. Yazli, boleh stop sharing dulu?
How to stop sharing?
Okay dah. Yeah. Okay, Dr. Siti, can you start share?
Okay.
Okay. Okay. Can you see my screen?
Not yet. Has started screen sharing though.
Okay. So I start my presentation today, which is entitled Rickettsial disease. Okay, can I start now?
Yeah, now we can see your screen. Yeah.
Okay, sorry for the delay. Okay, so the title of my presentation today is Rickettsial disease, eliminating the blind spot in laboratory diagnosis. So this will be the content of my presentation, which covers the causative agent, the global burden, Malaysian data, as well as lab diagnostic tools. Okay, first we go to the causative agent. Rickettsia and Aurelia genus are the causative agent to the Rickettsia disease. They are the obligate intracellular bacteria that require living hosts to survive and replicate. And the vectors for this bacteria is the arthropod, namely the ticks, mites, and fleas. And Rickettsia are transmitted to human via bites of hematophagous vector. And mode of transmission is via bites of the hematophagous and also entry of arthropods split into the mucosal layer. It is classified as the BSL-3 organism, as low infectious aerosol dose may cause disease, and it is potentially to be used as bioterrorism agent. Rickettsial originated from order of Rickettsialis, which divided into Anasplasmataceae, Ricketsiaceae family, and this will give rise to Rickettsia and Aurelia, and later Rickettsia will cause disease on spotted fever group as well as typhus group, and spotted fever group has more than 25 species belong under this disease group, whereas typhus group consists of Rickettsia prowazekii and Rickettsia typhi, whereas Aurelia susugamushi is the causative agent to scrub typhus. Okay, genus Rickettsia are divided based on antigenic and genomic classifications, and around 30 species are classified as pathogens. Whereas Aurelia susugamushi has around 20 pathogenic prototype strains being found around the world, and the classification is based on the variable region of 56 kilodalton outer membrane protein. And carp-related strain is the most widespread strain around the world. And this is a published strain that is found in Malaysia by Tay et al. Rickettsia are naturally maintained in vector population by vertical and horizontal transmission. Female vector transfer Rickettsia to the offspring via transovarian transmission, whereas the uninfected vector contracted Rickettsia from rodents and other infected vector. Humans get infected upon accidental contact with animal hosts or the vector itself. Those who work in agricultural sector, residing in rural area, or involved with recreational activities such as jungle trekking, camping, ecotourism are the high-risk group. Okay. Murine or endemic typhus are caused by Rickettsia typhi, and the main reservoir is the rodent, and the vector is the fleas, or in the Latin name is Xenopsila chopis. Similar to endemic typhus, scrub typhus, the main reservoir for scrub typhus is also rodents. However, other small mammal hosts can also be found, can also be the host for Aurelia susugamushi, that is the squirrel, shrews, and civets. And the trombiculate mite at larva stage, or better known as chiggers, is the vector. And there are 5 main Rickettsia species caused by spotted fever group in Southeast Asia. And these are Rickettsia honai, Rickettsia felis, Rickettsia conori, Rickettsia helvetica, and Rickettsia japonica. And there are various animal hosts and vectors, include fleas and hardtails. This picture shows arthropod infestation in different animal hosts, and you can see that Rickettsia infesting on the skin of the dogs and also rodents, and the trombiculite mites are in the rodents' ears, and this shows that there is exodus or hardtail in the dog's ear. And this picture shows that ticks burrow its head into the skin and feed until full and fall off. Which part of the world is highly burdened by Rickettsia? We can see that Rickettsia is widely distributed worldwide, and it is found in all continents except Antarctica. The high incidence rate was reported in areas associated with rodents infestation, poor hygiene and sanitation, and overcrowded areas. And different Rickettsia species were found in different parts of the world. And Rickettsia rickettsii is mainly found in the Central and South America, causing Rocky Mountain spotted fever. And Rickettsia prowazekii are found in Africa, South America, as well as some part of the Europe. And this causes epidemic typhus. And lastly, Rickettsia honai and Rickettsia japonica are mainly found in the Asia. Besides that, Orantia susugamushi are also highly reported in Asia, and particularly in the Susugamushi triangle, which consists around 10 to 30% of which has zero prevalence of around 10 to 30%, whereby 10 to 30% of the population has been exposed to scrub typhus before. And this triangle extends from Iran to North Japan and down to the East Australia. Okay, as Malaysia is also a country located in the Susugamushi triangle, it is presumed that there should be high incidence of scrub typhus in Malaysia. To know this, we look further into the local data. Okay, Rickettsia disease is one of the notifiable diseases under typhus infection. Interestingly, there were very low cases being notified, that is around 1 to 21 cases per year. Is this the true reflection of Rickettsia incidence, or is it indicates that Rickettsia is the most neglected vector-borne disease in Malaysia? So let's compare the data with 6 years seropositivity of Rickettsia disease among suspected patients in private hospital and East Malaysia. So it is showed that there are 10 times higher cases compared to the notified cases of typhus infection, whereas there are 10 to 200 cases per year of seropositivity Rickettsia disease. And scrub typhus has the highest seropositivity, followed by typhus and endemic typhus. Comparing the two data, we can conclude that many potential cases were not diagnosed and notified in Malaysia. Failure to notify a suspected and confirmed notifiable disease may be fined under Infectious Disease Act 1988. So the vast variability and non-specific presentation of Rickettsia disease has made it difficult for clinicians to rely on their clinical judgment alone. Thus, laboratory diagnostic tools play a major role in assisting the diagnosis. So firstly, let's look at what are the samples that can be sent to for Rickettsial tests. So there are 3 types of samples, namely the serum, whole blood, and scar tissue biopsy. And serum and plasma are used for serology tests, whereas Buffy code and tissue biopsy are used for the molecular tests. Amplicons from molecular tests are used for sequencing for further characterization. And there are also other non-conventional methods to detect Rickettsia, which are culture, MALDI-TOF, immunohistochemistry, and metagenomics. Except for immunohistochemistry, all these tests are more suitable for research purpose. Being a BSL-3 organism and intracellular organism, diagnosis of Rickettsial disease has depended heavily on serology method. This is the list of serology tests that is commonly used. And Rickettsial serology test is the method to detect and measure antibody levels. And antibody can be detected at every 7 to 10 days after illness onset. And both IgM and IgG are used for interpretation, as it may cross-react with IgM alone is insufficient for a serology interpretation, as it may cross-react with other bacterial infection. So both IgM and IgG are needed for a serological interpretation. And first week IgG normally refers to previous infection, whereas IgG that is taken 2 weeks after correlate with the current infection. A PET serum of acute and convalescent is needed to see the dynamics of serological response. Indirect immunoperoxidase test, or IIP, has been started in IMR in 1988, and since then it was used as reference test. It is acceptable by WHO as an alternative option to immunofluorescence test, and the use of fluorescent microscope was omitted by replacing fluorescein to peroxidase. It detects antibody to all 3 strains that representing the 3 major disease groups for Rickettsial disease. The drawbacks of IIP are it do not confirm species, as they are high seroreactivity within serogroup. It requires training and skills, and no standardized cutoff for international comparison. This picture shows positive antibody detection against Ornithia sussugamushi at 1 in 800 serum dilution. Okay. Besides IMR, IIP test is also performed in 4 other tertiary hospitals catering for their respective regions, and IMR provide continuous training, education, and result checking as a form of quality assurance program from time to time. Okay, now let's look at other serology tests that are commonly used. Wilfelix is an old test that has been used to diagnose Rickettsia on the basis of cross-reactivity antibody of Rickettsia to Proteus. Although poor in sensitivity and specificity, it is an option in resource-limited areas. ELISA is a quantitative method that uses outer membrane protein antigen to detect IgM and IgG. This is the most promising alternative test and have high correlation of ELISA with immunofluorescence tests. Next is the rapid test, which is only available to scrub typhus so far, which use 56 kilodalton outer membrane protein as the antigen. And sensitivity may range widely, thus it is recommended to be used together with PCR and ELISA, and results should be interpreted with caution. Now let's move to molecular tests, and tests available are PCR and LAM, and both detects nucleic acid. However, PCR uses thermocycler and LAM uses isothermal technique. And LAM is generally prone to false positive and lack of accuracy. So PCR detects DNA of Rickettsia, and detection is accurate at early phase of the disease, that is within 7 to 10 days after the onset. It is high in sensitivity that it detects as low as 10 copies of target genes. It is able to differentiate species by doing sequencing. And the detected Rickettsia DNA is a confirmatory of rickettsial infection. However, a non-detected rickettsial DNA does not rule out possibility of infection. This might be low due to other technical errors like low bacterial load or poor sample quality. So a Rickettsia PCR test would consist two PCR protocols. That is, first is to look for rickettsial DNA, and GLTA target genes is the highest in sensitivity and specificity. OMPB and OMPA PCR would be used to differentiate between spotted fever group and typhus group. And second protocol is to look for Orantia sussugamushi DNA, and the type-specific antigen gene, which is 56 kilodalton, is highly specific and unique for Orantia sussugamushi. And 16S rRNA and 56 kilodalton amplicons plus sequencing can be used for characterization of strains and species by phylogenetic study. Okay, now let's recap the type of diagnosis assay. Okay, a molecular test can be done within 7 to 10 days after onset of illness, and this is followed by an acute phase of serology test, which can be taken after 10 days but post-onset. And another serology test for convalescent phase should be taken 2 to 4 weeks after the first sample. And a confirmed recent infection is pronounced after 4-fold rise or greater in antibody titer. And combination of molecular and serology tests would complement and broaden the diagnostic window. Thus, it would allow definitive and reliable diagnosis. Next, we go to the lab criteria. The first lab criteria for rickettsial infection is to confirm a recent rickettsial infection, which consists of two criteria. That is, 4-fold rise in antibody titer using PET sample or detected rickettsial DNA. And another criteria that we would like to introduce, due to difficulty to get convalescent sample in most cases, and also narrow window period for the PCR, so a presumptive criteria for laboratory to confirm recent rickettsial infection is introduced. So this would be a 2-fold rise in antibody titer using PET serum, and also single antibody titer equal or more than 1 in 100 without PET serum samples that is taken within 30 days after onset. And this will allow an addition of case definition for rickettsia that can be notified. So this case definition that is proposed here is a probable rickettsial infection, which consists of clinically compatible case that has a presumptive laboratory evidence. So what are the blind spots in rickettsial laboratory diagnosis? This refers to the common errors, which are type of sample and also the time taken, and in addition is the interpretation of the results. So for molecular tests, PCR for rickettsial has been started in IMR since 1st August this year. And since then, we have received many requests for PCR tests. However, some do not some exceed the diagnostic window, and there is also no time being stated in some of the requests. So these normally are samples that do not meet any clinical criteria for Rickettsia PCR. So this practice should be immediately stopped, as it is a wasting of resources, and otherwise we would, if this practice is still continued, we will be changing the order option into order by consultation. And there are also tissue samples that are claimed to be scar, and as they are black scab on the skin. However, it turned out that this skin lesion is other illness, other skin lesion which is not a scar. So please make sure and confirm the scar presentation, whether it is correlated clinically by position and appearance before sending it for Rickettsial PCR. So next is the Rickettsial serology, whereby interpreting IgM alone can be misleading, as IgM for Rickettsia is not specific, particularly in spotted fever group and typhus group. The level of IgM can be variable at acute phase, so it may not be detected at acute phase, or may be detected but not rise with time, or it may persist longer than reported. And serology sample should be interpreted with time, the sample being taken. So if only one sample can be afforded, it is best to delay the sampling, as serology evidence does not become apparent until second week of the disease. So all these errors are essentially eliminated to prevent resource wasting and unreliable results. So now we come to the last part. How do we go way forward with Rickettsial diagnosis? So improve detection and get the right diagnosis is the way forward for Rickettsial diagnosis. So this can be done by continuous education among the clinician and healthcare worker to create awareness, and this will allow improvement in notification and get the real incidence rate. Continuous surveillance will remain critical to understand disease pattern, and lab-based surveillance can be taken as a starting point. When there is a significant number of cases being detected, R&D on detection method, resistance tests, and vaccine can be funded easily. So in a nutshell, Rickettsia disease is the most neglected emerging vector-borne disease due to challenging clinical and laboratory diagnosis, lack of knowledge and awareness, as unsuspected Rickettsial disease lead to no differential diagnosis on Rickettsia, and it won't be tested. And another point is that wrong detection strategy should be resolved by taking right tests at the right time, and this will lead to reliable results. You can have results or excuses, but not both. So with that, I thank you.
Okay, thank you, Dr. Siti Rose. Now we have time to answer or to address questions from the attendees. So let's address a question from the chat box, or the Q&A box. Okay, there's one question, I believe, for Dr. Siti Rose. What is the TAT for the serology test or PCR test?
So the TAT for serology test and PCR test are 5 days.
Okay, any more question from Dr. Peng, I believe? And then there's some question from the chat boxes earlier, but I hope those who have typed the question can indicate which cases, because Dr. Yazli has shared with us a few cases. So if you like the question to be addressed here, maybe you can unmute your microphone and ask your question. Dr. Jamaiyah and Dr. Siti Khairani, would you like to ask your question? We will allow you to unmute your microphone. Okay, I'm not sure how to unmute. I believe Secretariat has allowed participants to unmute their microphone, yeah? Can you try now, Dr. Siti? Dr. Khairani? Okay, so while waiting, okay, give me a minute. Okay, while waiting, just now Dr. Siti Rose mentioned about the out of diagnostic window, yeah? Maybe you can share with us. Okay, sorry, Dr. Siti. Okay, please continue, Dr. Siti Khairani. Please continue. We can hear you, but maybe you can speak louder. Okay, Dr. Siti can try again afterwards. There's another question. Okay, Dr. Siti, please continue with your question. Yeah. Ya, teruskan Dr. Siti Khairani.
Can anyone hear me?
We can hear you.
Boleh tapi saya tak dengar orang cakap. Hello?
Yep, we can hear you.
Yeah, if you cannot hear us, maybe your speaker.
I'm Siti Khairani. I'm from IMR. Hello, I have a question for Dr. Yazli. Hi, Dr. Yazli. I used to be a student at UiTM. When I saw some of your slides, I realized that some of your patients have low sodium. So I do realize that in patients with pneumonia, you do have some degree of SIADH, but you think there's a relation between low sodium and patients with rickettsial diseases?
That's a good question. So hyponatremia in infection can be multifactorial, okay? Depends on your hydration status. But in the end of the day, SIADH is something that you need to rule out if you keep pumping fluids and the sodium keep plummeting down. But when we identify the biomarkers, the lab variables among rickettsial, leptospirosis, dengue, okay, sodium per se does not become one factor that say, okay, low sodium, rickettsial. Now you can't use sodium to differentiate between these zoonotic infections. But you have to correct the sodium if they are symptomatic as per endocrinology wise. Does that answer your question, Khairani?
Okay, Dr. Khairani, please unmute your microphone. Okay, and then another one is from Dr. Jamaiyah. Yeah, can you ask your question again?
Yeah, here from IMR. I'm not so sure whether the first or second case, if I'm not mistaken, might be second case, the one that you show the scrub typhus title. There is an increasing four-fold rise from 1 in 100 on the first sample, and the second sample is 1 in 1,600. So are you looking for the IgM, IgG, or how is it? Is it both?
Actually, you were very soft. Yeah, maybe you can try to speak louder. Or Dr. Yazli, can you hear her?
Yeah, I can hear the question.
Okay, maybe you can try to answer.
So basically, IMR under Siti, okay, run both IgG and IgM, okay. But in that chat from Columbia Asia client, okay, who was the contractor, so the IgG was surprisingly the one that came up first and raised rather than the IgM, okay. So we know that previous infection will trigger IgG, okay, faster than your IgM, okay. I'm not surprised that he's been exposed to Orenshaw Susugamushi infections multiple times prior to this, okay. Although in some papers they quote that Repeated infection will not give rise to NHK because of your skin familiarization with previous exposure, okay? But there's always not a true rule that we should keep to everybody lah. But for that particular guy, yes, he has a huge HK, and yet serologically it doesn't connect with our impression that, hey, first HK, first exposure, no. So instead of the IgM, the IgG is the one that responded to the infection, okay? For Orencia susugamushi per se, we use IgM in Mahidol because we're not afraid of cross reactivity to other strains, okay? Because in the end of the day, it's just your Orencia susugamushi. Problem would be in spotted fever typhus, okay? Because if you use IgM alone in spotted fever typhus, you may not be able to identify what strain, because most spotted fever are non-pathogenic, macam leptospirosis lah. You have many serovars of leptospiro, but most of them are non-pathogenic. So sama macam spotted fever typhus. But for Rickettsial, for Orencia susugamushi and murine typhus, we are quite fine with using IgM alone, okay, without exciting on the GG part.
All right. Next question from Amira Amin. Is there any rapid kits that has been evaluated by IMR for Rickettsial diseases? And any kits with MDA registration? So I believe that is for Dr. Siti Ros.
So far, we do not receive any kit for evaluation. And I do not know if there is any kit that has received the MDA.
Okay, thank you. The next question from HPUPM, I believe from our students here. Are we expecting a rise in rickettsiosis during this coming flood season? And should we empirically treat too? And how to increase awareness among clinicians to send investigation for Rickettsial? So perhaps Dr. Yazli can address this.
That's a good question. So expect whole blood to be sent to IMR, Dr. Siti during flood and post-flood season. Okay, that's how we can answer your diagnosis, whether this is scrub typhus or no. But yes, the mites will go out during rainy season when the temperature is colder than the temperature under the ground. So that triggers them to go out and feed. But bear in mind, rodents will run away, okay, from wet areas to dry areas. So if they carry Orencia or if they carry Rickettsial typhi on their body, okay, the same things can happen to human as well. So bear in mind, overuse of antibiotic is never good. Okay, it creates a lot of trouble rather than treats. Okay. So have some good thoughts on how you approach any patient. Okay, so any sick patient, I'm happy you throw in doxycycline with any beta-lactam. Okay, you never know what's the diagnosis. This could be lepto, this could be myeloid. Okay, ceftazidime plus doxy, or ceftriaxone plus doxy, benzyl penicillin plus doxy. If you think this is a very sick patient, zoonotic exposure. Those who come without and organ damage, okay, those who come with good heart, good liver, good split, good kidneys, okay, you suspect Rickettsial for whatever reason. He lives in rural areas, rash, headache, although no HK, okay, if you platelet a little bit low but dengue negative, okay, yes, doxycycline alone should be sufficient, okay, because if you miss mild leptospirosis, your doxycycline can still treat mild leptospirosis. Okay, but pay attention to the patient day by day. Okay, if doxycycline fever settled, there you go. Okay, make sure that your whole blood that you send to IMR come back as detected or no. If day 2 on doxycycline patient still not responding, then you go say unlikely to be Rickettsial. Okay, and throw in your beta-lactam antibiotics. That's how I think the approach should be lah.
Okay, next question from Dr. Murni Hayati, who has raised her hand. Can you please unmute? Okay.
Dr. Yazli, just want to ask few of the cases. I think at least 2 of the cases has IgM positive for leptospirosis rapid test, and also some of them also have titer for MAT. Leptospira MAT. So does that is already 2 different tests for leptospira, and at the same time there's positive finding for Rickettsial investigation as well. But the patient was not responding to leptospira treatment, right? What do you think of the leptospira positive findings in the investigation? Was it a false finding or just a mere background seropositivity only, or is it a co-infection?
3 question, Nordin. Banyak soalan tu. So that's a good question. I was hoping somebody picked that up. Okay. So in the end of the day, MAT is like any serology. Okay, you cannot rely your MAT based on first reading only. Okay, that's correct way to diagnose lah. Okay, so and in the end of the day, MAT is not as easy to interpret. Okay, so one MAT 200 can have 600 in some other species, you know, the cross-reactivity in MAT. So if you want to diagnose leptospirosis, make sure you have a convalescent MAT. So yes, that patient has a background immunity to leptospirosis. Okay, we didn't have his repeated. This is quite difficult to get a convalescent sample. Either they discharged early, didn't come back. But in multiple patients who we have a convalescent sample that we compare for leptospirosis, we see a lot of background titer. And 200 after that turun hilang. 200 after that sama. And 200 after different strain yang 200. So again, the MAT for that patient is a non-diagnostic MAT for leptospirosis. Okay. And not surprisingly that the beta-lactam antibiotic does not treat the patient lah. Okay, it's not a failed treatment for leptospirosis. So never trust single titer result.
Okay, and Dr. Siti Karani, you have raised your hand, I believe, for another question. Dr. Siti Karani. Okay.
Dr. Yazli, I believe one of your cases was a patient that expired with a very short history of fever for 2 days and reduced GCS, am I correct? Hello?
Yes, you're right.
Oh, okay. So from what I understand, in order to arrive to that, to get like a positive PCR, the symptoms, the testing should be done after at least 7 days of the onset of symptoms. But if the patient comes very acutely, how are we supposed to diagnose rickettsia? Only based on history and physical examination?
So we had 3 patients who died from CNS infection. Okay, acute fever and then confusion and seizure. These 3 died. These 3 spotted fever. We can't get to. One patient had a CT brain done, nothing much to suggest of meningeal enhancement, so it's more encephalitis kind of thing. Unfortunately, we did not do any lumbar puncture in any of these 3 because of logistic reasons. Okay, but in the end of the day, blood cultures did not grow anything. It's not a kawasan of Japanese encephalitis. There's no porcine area there, so we did not think of JE much. Okay, but the 17 kilodalton PCR for spotted fever is the only one that was positive. So yes, CNS infection from Rickettsial from spotted fever is not unknown. Okay, it is there. As in macam Orangea susugamushi scrub typhus with pleural effusion. It is there. Okay, if you look it up, many people have started to describe this atypical presentation of Rickettsial infection. The most neglected part is the CNS part. Okay, so we're not surprised that they died. Okay, so if you want to make a diagnosis, send the whole blood. Okay, because in the first 7 days, the first 14 days, the bacteremia load is high. Okay, so whole blood will catch it because in the end of the day, you know, it's intracellular organism. Okay, we'll spin it, we get the buffy coat and extract the PCR from there. Serology may not pick up during the first 7 days of illness. Okay, but what I'm saying is, if you suspect this is a severe infection, when we go to CNS, it's severe infection. Don't play around. Don't just be happy with your acyclovir and rosafen. Okay, you may miss rickettsial infections. Okay, so throw in doxycycline or rifampicin kalau you berani. Okay, because to cross the blood-brain barrier, rifampicin is much better than doxycycline alone. So I wouldn't be hesitant if this patient fits the category of possible rickettsial infection. Rural area, acute history, rash will help you a lot, and nothing to suggest of other infection. HIV negative, okay? I will throw in either doxycycline or rifampicin if this is very bad. At least you need something to cover any intracellular infection in the brain.
All right, thank you very much.
Thank you. There are two more questions before we end our CME for today. But before that, I hope to get attendees to fill the form that has been provided by Dr. Anis, because we need that for our record, and especially we welcome your suggestion for our future topics under the MSIDC Zoonosis Interest Group. Okay, next question is from Dr. Ampang. What is the duration apart to send the PET sera? So by the time we perform second test, patient should have either recovered or got worse. Okay, Dr. Siti, maybe you can answer maybe can address that question.
The recommended time period is around 2 to 4 weeks apart. That is taken from the first sample lah. First sample to second sample should be around 2 to 4 weeks apart. Okay.
Okay, next is from Dr. Ridwan, but maybe Dr. Ridwan can unmute your microphone and specify to which presenter the question is for. Your question is the CT values are too low. How do you think that it is a true amplification rather a probe degradation as shown in other probes seen on the graph? Dr. Ridwan, can please specify that question to which presenter or which presentation?
In the T8028 patient, orang asli, where the IFA is 1 in 16,000, I think the CT value is high lah. To me, anything more than 40 is high. So it's 42, 40, 39. Okay, so we run triplicate rather than duplicate just to make sure that there's no other like degradation elements and whatnot lah. So we clinch to the diagnosis. So we berani to kata this PCR is positive because hey, the IFA is positive. This is true Oracea susagamushi. We managed to clinch to the 50 kilodalton. We managed to strain it up to be turned to Kawasaki. So when we do PCR, so we need to know what happened to the patient when the PCR was done. Okay, so in this, for example, patient presented on day 7 of illness, but the blood was taken on day 10 of illness, while azithromycin has been in the blood in the last 3 days. So I'm not surprised actually that the bio loads of the Oracea susagamushi degrades lah rather than multiplying. So katakanlah ada datang on admission, we haven't started azithro yet, okay, I'm sure the CT value will be much lower, i.e. 25, 30 lower CT value. So in this case, although it's high, so I think it's high for reasons that the Oracea is dying off, okay, with azithromycin in the blood. So hence it's important if you ask for a PCR, tulis betul-betul in the form how many days of illness, how many days of treatment, is the blood taken while patient on doxy or azithromycin. At least with this information, we can interpret the CT value with more clinical reflections rather than just pure number on the PCR alone. All right.
Okay, thank you. And there are also some feedback about our session today. Thank you very much for your feedback, and also some question about recording and slide. The secretariat will get back to you. If you have given us your email contact info, we will get back to you about the recording. I guess now is 11:35. I think that's all. Maybe one take-home message from each presenter before we end our session.
Siti?
Yazli first.
Ladies first. Okay.
I think I've given my take-home
My take-home message is use Siti kepandaian in IMR. Okay. We don't know the data. We cannot talk about any of this. Okay. So IMR and Siti plays the most important role to show that Rickettsial are still around us. How bad of them, a patient, if they die without diagnosis, we never know in the end of the day. So the take-home message is diagnosis must be made with a good confidence, okay? And then we go from there to create guidelines, to create treatment, to create algorithm. Otherwise, we wouldn't have a good head start, okay? So send your results to IMR.
Okay, Dr. Siti, any more to add?
My take-home message would be aware that this is one of the emerging tick-borne diseases, and we can all work together to improve detection and get the right diagnosis to improve our incidence rate. That's it.
Okay, so with that, I would like to thank both our presenters, their secretariat, and especially our participants, for your engagement and also participation. And thank you for staying with us from the beginning until the end. Thank you very much and have a nice day. Assalamualaikum.
Thank you. Salam.